All right. Hello, everyone. My name is Neuro Badjatia. I'm a neurointensivist over at University of Maryland Shock Trauma, and I was going to talk to you guys about nutrition in the Neuro ICU. Overall objectives, what we'll kind of get through in this next 20 minutes or so is, kind of go over the metabolic response to critical illness, which I think is fundamental to understanding how best to provide nutrition and what nutrition means to neurologically injured patients. And discuss the kind of clinical concepts related to substrate utilization and secondary endpoints in our patient population, and then end by just reviewing some basic clinical evidence regarding what I would call common nutrition practices and how we can essentially achieve our goals more efficiently in our patient population. So to start with brain injury and hypermetabolism, what we know is that the brain accounts for about 20% of total oxygen consumption. It's really tightly correlated with severity of injury, and though we tend to use a lot of catecholamines in our patients as norepinephrine infusions and whatnot, it's really not impacted by that exogenous catecholamine drive as much as an internal sympathetic surge. And as a result, kind of providing the early metabolic support and proper nutrition is really necessary in order to counteract the hypermetabolic response and the impact it can have on outcome. And so this is kind of the classic description that's several decades old now, looking at energy expenditure over time and looking at kind of the ebb and flow phase of the metabolic response after critical injury, and what we need to think about, we're always thinking about in our patients when they first arrive, but they have significant impacts not only on their clinical state as it relates to their cardiopulmonary and neurologic status, but also underlying metabolic status in these patients. So if we were to break down the metabolic response to injury and think about what happens acutely with the sympathetic and hormonal hypermetabolic response on substrates endpoints, you see liver and muscle is impacted, the fatty deposits are impacted, muscle again is impacted, and the endpoints we're looking at are glucose, fatty acid metabolism, and amino acid depletion. So just sticking with what I'll kind of go through is in each of these slides is go through each of these endpoints or substrate utilization endpoints one by one. And so to begin, we'll kind of look at glucose metabolism. And so with glycemic control, traditionally we've wondered, what is the right goal for the serum glucose in our patient population, that, this graph really well describes, I think, the concerns that we have is that if we go too tight on the glycemic control, we actually increase the chance of brain injury. And certainly if we get hyperglycemic, we see an increase in brain injury as well. So in this critical care population now, at least almost 20 years old, the Vandenberg studies really demonstrated that there may be some benefit for tight glycemic control, and for the most part has been adopted with variation across the general critical care population. When you look at all the controversies within what tight glycemic control does in those populations, the one data point that seems to be irrefutable is that tighter glycemic control does improve PNS function, does improve that neuromuscular function in these patients. There's always a long-standing concern for hypoglycemia, and this is where it becomes an issue for brain injured patients. What is hypoglycemia for an injured brain? Because we know after brain injury, glucose utilization increases. And there's been a lot of different looks at how to understand this, and some of the initial looks with microdialysis done by Paul Vespa and colleagues at UCLA. He actually looked at the brain energy expenditure or brain energy crisis in patients with TBI and other acute brain injuries using a microdialysis probe, and they were able to measure how often they were able to see low brain glucose levels in patients who had intensive glucose control versus less intensive glucose control. And what they found is that the incidence here, the percent of time where they saw low brain glucose was much higher in the patients with intensive glucose control. And that seemed to also associate with an elevation of lactate to pyruvate ratio, indicating when in combination with the low brain glucose, a kind of a metabolic crisis in the brain. And so really several studies in the interim have demonstrated that, the clinical evidence to translate to this, what we're seeing with the microdialysis studies, is kind of diffuse. There was a meta-analysis that looked at about 16 studies and looked at the impact of tight glucose control versus loose glycemic control in a multivariable, in a multiple disease states, including stroke, subrectal hemorrhage, and TBI, and essentially found that there was no benefit of tight glycemic control. And observed that across these studies, there was a higher incidence of hypoglycemia with tight glycemic control. But it really wasn't until more recently, this past year, with the publication of the SHINE study, that we actually have good level 1 evidence, at least in one of our patient populations, the stroke population, in terms of what tight glycemic control versus loose glycemic control may have impact on outcome. And this is a wonderful study that really tried to answer the question, does intensive glucose control improve outcome in patients with acute ischemic stroke and those who are hyperglycemic with acute ischemic stroke. And their target here was targeting 80 to 130 as kind of their tight glycemic control versus standard, which was 80 to 179, or essentially letting patients go up to 180 milligrams per deciliter. And as you can see in this graph here, they were able to achieve the glycemic difference between the two populations with their protocol. But in the end, what they found was that there was no improvement in 90-day functional outcomes in patients who were treated with tight glycemic control as compared to those who had standard of care glycemic control. So I think based on this level 1 evidence, certainly for ischemic stroke patients, we have good data to suggest that we don't necessarily need to be targeting 80 to 130 or tight glycemic control in this population. As far as the other patient populations that we deal with in the Neuro ICU, the evidence is mostly observational, and there's a good, I think, well, let's say translational evidence using microdialysis data that would also indicate the same. So essentially in our population right now, based on our current standard of care, most would agree that we probably should avoid tight glycemic control out of concern for risk of serum hypoglycemia, but also brain energy crisis in patients with acute brain injuries. Now, what about amino acids and as a kind of byproduct of the breakdown of the muscle? You know, the catabolic response to critical illness is pretty universal. Malnutrition, as defined by protein catabolism, is pretty prevalent across all ICU patient populations, and it's strongly associated with not getting enough calories, but also not getting enough protein. And the adverse effects that have been reported in populations include impaired ventilatory drive, weakened respiratory muscles, skeletal atrophy, and overall poor functional recovery. And this is a kind of nice schematic that demonstrates what's happening in patients who have whole body protein catabolism associated with also hyperglycemia. They have a breakdown of muscle products in order to provide primary fuel for an injured patient. And in the patients with brain injury, we think that this is a significant contributor to their poor outcome long term. And in fact, when we look at what's been published and what we've seen in traumatic brain injury patients is that there's a strong relationship between underfeeding, negative nitrogen balance, and poor outcome. And this is a nice study that was published almost a dozen years ago now that looked at the impact of initiating enteral nutrition early versus late in a population taken from New York State research database. And what they found was that patients who were fed at a later time point or to achieve maximal nutrition level after the first 7 days had a higher mortality rate than those who were fed at an earlier time point and reached their maximal nutritional level earlier than 7 days. What this study doesn't answer is what happens with specific micronutrients and specific amino acids such as glutamine that may be playing a role in determining secondary endpoints such as infectious complications. And I think that's where right now the field is looking at kind of the micronutrient level and specific substrate utilization rather than just looking at large targets like protein, perhaps looking more at amino acid profiles and also, as we'll talk about, fatty acid profiles. Now, what about the non-TBI patient population? This is a study that we had conducted a few years ago in SAH patients and looked at their overall impact of nutritional status during the first 14 days on 90-day recovery. And what we found was that protein energy catabolism was associated with the inflammatory status, and negative nitrogen balance in the first 2 weeks was actually an independent association with 3-month recovery. And in a subset of this study, we actually looked at specific amino acid depletion, such as glutamine levels, and found that lower glutamine levels in the first 14 days were associated with 3 months performance on recovery measures at 3 months. So I think what we're seeing is that the impact on amino acids, the impact on muscle breakdown and subsequent increased utilization of amino acids has having a significant impact not only in the traumatic brain injury, but perhaps even the non-traumatic brain injury patient population. Now, what about fatty acids? Now, lipid oxidation after injury is very common. In fact, high free fatty acid levels is a common phenomena across all injury patterns, whether it be brain injury or systemic injury. It's been implicated in complications related to sepsis and ARDS, the increase in the free fatty acid component, especially the omega-6 free fatty acid component. When you think about what the mechanisms are, it's the arachidonic acids metabolites that are actually associated with further inflammatory status. And then again, in ARDS patients, they shift to omega-6 fatty acids may be associated with poor oxygenation and recovery. Well, what about in brain injury patients? And there's early data from CSF amino acid metabolites in patients with subarachnoid hemorrhage indicating that increase in levels of arachidonic acid metabolites, or so-called omega-6 metabolites, were associated with vasospasm. And when we looked at a very similar patient population and looked at serum omega-6 to 3 ratios, we saw a shift occurring in higher omega-6 to 3 ratios in those who went on to have delayed cerebral ischemia. So this brings up the idea of perhaps changing the content of fatty acids in patients after brain injury. And this is a nice kind of schematic of looking at what supplementing with omega-3 fatty acids could potentially do in terms of the pathogenic pathway related to increase in omega-6 to 3 ratio. So by providing more omega-3 fatty acids, we may be able to essentially change the inflammatory profile and change the neurotransmitter profile related to glutamate excitotoxicity and reduce oxidative stress. This is a kind of a nice theoretical paradigm that you can apply to not just traumatic brain injury, but also non-traumatic brain injury. And in fact, there's a study that was conducted out of Asia where they looked at 162 subarachnoid hemorrhage patients and actually supplied omega-3 fatty acids in the form of EPA up to post-bleed day 14 and measured the impact the EPA levels had on, measured that they were able to achieve higher EPA levels and what impact it had on outcome. And they actually stopped this study a little bit early because they found that in an interim analysis, the patients who had received omega-3 fatty acids were having a significantly lower rate of symptomatic vasospasm and cerebral infarction related to vasospasm. Now, because this is a kind of a proof of concept phase 2 study, they had not looked at or had not been powered to look at outcomes, so they did not really change an outcome. But essentially, we're able to show that by giving omega-3 fatty acids, you're able to increase the levels in these patients and perhaps impact on delayed cerebral ischemia. So I think this is a story that we'll probably hear more about in the coming years as to whether or not we should be supplementing our patients with omega-3 fatty acids in order to change the shift or the relative ratio of omega-6 to omega-3s post-injury in order to provide a more beneficial state, physiological state for our patients. So when we think about substrate utilization and we think about the traditional paradigm of looking at glycemic control, amino acid profiles, and fatty acid expression, there are alternative and newer paradigms that are being developed that I think are worth noting and discussing. And the first is looking at ketones, perhaps using this as an alternative fuel. And what we've seen is that given the concern for hyperglycemia, negative nitrogen balance, and shift towards omega-6 fatty acids, should we be using a low-carb and high-fat protein diet, or perhaps even a ketogenic diet? And this is a nice schematic that demonstrates potentially why we should be doing this, though we certainly need stronger clinical evidence to support it in practice. And what we're seeing, this is just using a TBI model, but certainly you can use any brain injury model. What we see is what happens in TBI or in a brain injury model is that you have a decrease in glucose uptake, increased glycolytic processing of glucose, and then overall decrease in ATP production and increased oxidative damage to proteins, lipids, and DNA. And by supplying ketones as an alternative fuel, quote unquote, alternative fuel, you can actually increase the energy of ATP, increase glutathione peroxidase activity, and decrease overall free radical expression in these patients. And I think we're starting to see some early work that's demonstrating that this approach is beneficial to patients. The feasibility is an issue because to try and achieve ketogenesis in a patient population that's critically ill is not trivial. Everything that we give our patients is often emulsed in some type of glucose that includes any of our medications and certainly some of our infusions. And so it really does take careful planning and working with your ICU nutritionist to try and identify all the sources of potential carbohydrates and eliminating those from the patient if you're going to try and achieve ketogenesis. And I think the other final kind of comment related to where we are with substrate utilization and nutrition in the ICU has to do with thinking of nutrition as part of a multimodal approach to improving outcome after critical illness. So if we take our paradigm of a patient who's injured and has a pro-inflammatory status and develops a malnourished state, results in loss of lean muscle mass, and at the same time that they're injured, they're also inactive because of their injury perhaps itself or lack of overall mobility or mobilization. That also promotes lack of muscle mass. So there's multiple pathways at which you can see this loss of muscle mass having an impact on outcome. And so using nutrition as part of the therapy where you provide the appropriate protein supplementation, perhaps also provide immune modulating therapies such as glutamine or free fatty acids, omega-3 fatty acids, combined with substrate utilization, which is mobilization and exercise, may be the real way to provide an appropriate setting for improving outcome after critical illness. So using nutrition as one of a multiple step therapy where exercise or substrate utilization is actually a key part, a key component, may be the best way to improve outcome after a critical illness. So I wanted to shift gears here for the last few minutes and talk about what some of our evidence is for our basic daily practice in the ICU with nutrition. And I think in the last several years, there's been several trials that have been published that have addressed some of these core issues dealing with timing, initiation of enteral nutrition, whether or not we should be using trophic feeds, and how, if at all, should we be monitoring gastric residuals. Many of the studies that I'll be talking about in these next few minutes are done in the general critical care population. The neuro population in each of these studies was about less than 15%, but I think the themes are common and they can be applied to our neuro critical care patient population. The first study is actually the food trial, which is it was a stroke trial, actually, specific to our patient population. And it was 3 different trials kind of combined where they actually, in the first trial, compared regular food versus additional supplements and those who can take PO in the first month of injury. Second trial was a comparison of immediate enteral nutrition versus 1-week delay in enteral nutrition. And the third trial is a comparison of NG2 feeding versus PEG feeding within the first month. And the composite results of this study is a large study done in Europe. What they found was that early tube feeding was associated with absolute risk reduction of death, or absolute reduction in risk of death, and associated with a reduction in death or poor outcome. And that you can see that here in terms of within the first 7 days, if you really should initiate, just like we commented on in traumatic brain injury patients. Early PEG feeding, however, within the first 7 days was associated with increased risk of death and poor outcome, indicating that perhaps we shouldn't be placing PEG tubes too early in our patients in order to avoid the potential complications related to the disease, to the PEG tube placement itself. And then when you think about early feeding in the TBI patient population, there's a nice meta-analysis published a few years back demonstrating that a reduction in mortality and reduction in poor outcome or an improvement in good outcome was associated with those who started nutrition early rather than late after brain injury. So really in our stroke and TBI patient populations, we have good data to suggest that early nutrition is favorable, and there's no reason to think that that wouldn't apply to our other patient populations in the Neuro ICU. What about monitoring gastric residuals? This is a common theme that comes up when we talk with our bedside nurses and our nutritionists. Should we be routinely monitoring residual gastric volumes? And this is a study that actually kind of looked at that. And again, in a med-surg ICU patient population, about 15% of these patients were neurologically injured. What they found was that if they did not monitor for gastric residuals and just continued feeds, that they didn't find a difference in the infection rates. And the proportions of patients who received 100% of their calories was higher in the patients who got who the nutrition was never interrupted for checking of gastric residuals. So I think the take home from this is that it's perfectly safe to not check residuals in patients who are on enteral nutrition unless there's evidence of gastroparesis or an ileus as documented by a thorough assessment. By avoiding checking gastric residuals, you're essentially going to be able to achieve fuller nutritional goals in your patient population. What about starting slow and going up to total caloric goals versus starting completely at full enteral feeding? And this is the Eden randomized trial, and this is, again, focusing in on a medical population with acute lung injury. And it was a randomized controlled trial providing full enteral nutrition versus just 25 cc's an hour trophic, so-called trophic feeds in the first several days. Overall, they did not find any difference in outcome, including motor and cognitive recovery at 6 months, and overall did not also find any difference in total calories by day 6. Now, one of the critiques of this study was that they really, if you look at their overall achievement of goal in the intervention arm versus the control arm, was not that different early on or even within the study period itself. So really, in both patient populations, they were achieving pretty full caloric requirements, even though they were trying to randomize to full versus less than full caloric requirements. I think the idea here is that we really, there's no necessary benefit there was no safety concerns with starting at full enteral nutrition either. So if we were really trying to achieve our total calorie goals early on in these patient population, I think starting at full feeds is a good idea. Though based on this study, there may be reasons in certain patient populations where it may not be feasible that you can achieve at least initial trophic goals as long as you get there within the first few days. So to kind of overall summarize, when you think about the clinical trials, there's again a delay in either initiating or achieving target caloric goal after brain injury. And we kind of go back to our kind of basic concepts. We know that brain injury is associated with a hypermetabolic state that leads to significant energy deficit and catabolic state. Our recent studies are advancing our understanding of inflammation, hypermetabolism, and substrate utilization in these and how they impact on secondary injury endpoints. And really, I think the future of where we're heading with this is that we're going to hopefully devise targeted nutritional therapies that are part of a multimodal paradigm to overall improve the metabolic health of our patients acutely while they're with us in the ICU, such that when they're on the recovery path, they're in a better physiologic state to do so. And that's what I wanted to discuss today, and thank you for your time.